I think a lot of people probably see a psychiatrist once in their life. And if it's a good experience, maybe they get better. And if it's a bad experience, they say, you know what, I knew it wouldn't work. I don't even know why I did it in the first place. I knew these people were just pill pushers. And I just think it's too sacred an interaction to not be doing everything I possibly can to improve the quality of these interactions for everybody, really.
Welcome to Didactic. I am Dr. O'Leary, a recent graduate of a Child and Adolescent Psychiatry Fellowship Program. Today is Sunday, August 2nd, 2026. I have been doing this podcast for about 5 years. And now that I am at a new phase in my career, I've been thinking a lot about things that have happened in the past. I remembered an interview I did with Dr. Mark Mullen about 2 years ago. The point of the interview was to introduce other people to his podcast, Psychiatry Bootcamp, which is one of the best resources for early career psychiatrists that's out there. But during the interview, we got into some territory that I did not expect. I sat on this content for a couple years thinking about it, and I think it's finally time to share it with everyone. So many of the themes we discussed kept returning to this idea of the Therapeutic Alliance. Why did we become psychiatrists in the first place? What do we need to never forget? What makes us love what we do? This episode explores the themes of the Therapeutic Alliance. An alliance is not a thing that a patient has or that a provider has. It's a thing that they form together. It's something that they share. And the only way you can have an alliance is if both parties are committed to something. The psychiatrist needs to love what they're doing. The patient needs to want to be there. Somehow, this can happen. And we explore some of the ingredients that are necessary to form this sacred alliance. But I'm not going to waste any more of your time. Here is Dr. Mark Mullen.
I think if you go into psychiatry and you think that you can operate the same way that a surgeon or an internal medicine doc would, that's a real disservice to your patient. Our diagnoses are different. Our frameworks for understanding things are different. The way we understand our medications are different. And I think we need to respect that and appreciate it. I really wanted to start from a place of, all I know is that I know nothing. And we're going to give you some nuts and bolts here, but we are not even scratching the surface of what it means to really be a psychiatrist and make some of these decisions. What is our role here? Is there anything we're doing that could be dangerous? Are we making sure that we're protecting normal human functioning, not over-medicalizing normal human problems? Because I think that that's a real problem right now. And I think that if you don't have the appropriate training to understand what frameworks we're using, the tools we have, and the limitations of those tools, you wind up giving someone 5 labels that mean different things, and each label has an FDA-approved first-line treatment. And so now you have a person who is one person with a unique set of problems, but they have 5 diagnoses, and therefore they're on 5 medications. And I think I just see it too often in clinical practice. So I wanted to make sure that no one listened to Psychiatry Bootcamp and then went out there and kind of practiced that checkbox psychiatry. That was my worst fear.
Yeah, I've noticed that too. Systems are overwhelmed with psychiatric patients, and the way that insurance companies are structured and how we have to do billing creates a strong pressure to use screening instruments as diagnostic tools because of the time limitations instead of taking the time we need. And I think that drew me to psychiatry in the first place was how much time they let me spend with my patients and how I got to know them. But for models of care that we have, that's not feasible a lot of times. There are a lot of studies out there that show the number one factor, no matter what kind of psychiatry you're doing, is the therapeutic alliance. Getting to that takes time, and it's really the art of psychiatry.
I think it takes brave leaders to defend kind of the spirit of psychiatry, the ethos of psychiatry, the fact that connections in and of themselves with other humans can be healing, the fact that many humans are resilient and over time they may get better on their own. But there's a lot of different entities at play in the world of healthcare that have interests that are different than simply providing the best care possible, right? There are large entities who have a vested interest in making sure appointment times are quick, making sure that we can solve a problem with a pill instead of having to invest hours of human resources into it. And so I think it's really incumbent upon us to defend that ethos of our field and say, it's really easy to practice bad psychiatry. I mean, it really is. We have very limited objective tests for how our medications are working, if people are getting better, right? It's really not hard to fill out some checklists and prescribe a pill that somebody takes. I think it's really hard to practice excellent psychiatry and to build connections with people who are not predisposed toward building strong connections, and to have a strong enough connection that that person will trust you and trust your opinion and be honest with you so that you can get an accurate assessment and a treatment plan that has a chance of working. And I think it's infinitely difficult. So we need, brave leaders to push back against some of these entities and say, wait a minute, we need to spend time with our patients. We need to understand them on a level that goes way beyond the PHQ-9.
I know that for certain physicians who practice with patients who are trying to do things like improve their health in general or lose weight, they have certain goals. They don't accomplish those goals in the office. They accomplish those goals in their life, and resources that help them to do something they can do, be accountable to something, and enjoy it. I think a lot of that can be incorporated more into behavioral health practice to get people connected. And the world right now seems, the more connection we have, it seems like the less connected we are, and it's a strange problem.
I think that we are overdiagnosing. I think that we are overprescribing. And I think that we are grossly underdiagnosing people that really need our help, and grossly underprescribing for people that we could drastically change their lives if we were able to build a therapeutic alliance and get them on a medication that they need. I think that it definitely cuts both ways. And that's what I try to keep in the forefront of my mind in my clinical practice. Is this someone who we are over-labeling, over-prescribing, and we need to normalize their human experience and provide some empathy? Or is this someone who we are shamefully neglecting as a society, and I need to do everything I possibly can to help them get better? I think that the population of patients that we see ranges extremely broadly from distress that should not even be diagnosed or even have a treatment plan. It should just be normalized and say, yeah, this is a really difficult thing, and it's really difficult to be a human being, and I'm happy to talk with you while you go through it or refer you to a therapist who can. And then I think there are definitely people on the other side of the spectrum where they're going to be incarcerated or dead within a year if we do not really get on our horse and intervene in this person's life. So that's the lens that I try to take.
Johns Hopkins especially talks about this thing called The Perspectives in Psychiatry. It's one of the books that I read as part of it was didactics, but it was voluntary didactics. It tries to bring together all sorts of different dimensions that a patient might experience. It talks about the more innate things, like even someone's IQ and their ability to understand and interact, with their world, and how effective they can be at that. And, what kinds of things might overwhelm a person like that versus a person who is extremely high functioning, dealing with a ton of anxiety, but, still able to go to work every day and do their job. And then think about a patient's life story. I think when most people go to a therapist or a psychiatrist, they kind of have this idea that they're going to tell them their life story, that they're going to get to tell them the story of them. And I think very few times is there enough time for them to be satisfied and desire.
Yeah, I think we do underappreciate that. And I think that there's really no one size fits all approach to anybody. I think to your point about people's expectations coming in to see a psychiatrist, we really need to honor that. From a common factors approach, this is what we would call the therapeutic ritual, right? And rituals have been important throughout all of human history. Any society you look at has had really important, meaningful, spiritual rituals. And in our society today, when you're not feeling well mentally, one of those rituals is coming to a person with expertise in the area, whether it's a therapist, a counselor at school, maybe it's a priest or clergy, maybe it's a psychiatrist. But you come and you sit in front of this person and you pour your heart out, and this person gives you a response that is in some way, this person gives you a response that helps you to feel understood and not alone and able to get better. And I think that ritual in and of itself is incredibly powerful, and we need to be respecting that and harnessing that as much as we possibly can.
part of me thinks that like if I were ever a program director, the very first set of didactics I would send someone through would be how to establish a therapeutic alliance. Like not how to prescribe medicines, not how to not what therapy would be best for this kind of patient, but how to get the patient to trust you and how to not in a manipulative way, but in a way that you can now really start to understand them. And because that is like the effect sizes are enormous compared to anything else that we do. And in fact, the effect sizes of the other things we do highly depend on that as well.
Exactly. And that I couldn't agree more. And to be honest with you, that is the first change that I made as a clerkship director. Was I looked at the entire clerkship and I said, this whole thing should be about the therapeutic alliance. That is what I want all of these featured doctors to know about psychiatry. I don't really care if they ask about caffeine use at every visit. I do care if the person that they are treating feels like this doctor cares about them, understands them, can listen to them, has expertise. And I could not agree more that that needs to be the foundation of all training in psychiatry.
Yeah, and there's so much, because the story we tell is so huge and there's so many details we could ask about a patient's life. Things like you mentioned caffeine, and there's all these things that if you work in an institution where a reviewer like the Joint Commission comes in, they're going to look at people's notes and they're going to say, well, you didn't ask about this, and you didn't ask about this, and you didn't ask about this. And then that becomes the priority. Instead of having a very comprehensive view of the patient and like, well, you'd have to check all of these boxes. But in my practice, I have found that to be mostly noise and not much signal. And finding the signal, I think, has a lot to do with letting the patient tell you what that is.
1000%. Couldn't agree more.
You mentioned this word a couple times when I was chatting with you. You said a humanistic approach. And what do you mean by that?
I think, to be honest with you, to unpack that, I have to tell just a little bit of my own story. When I sought mental health care for the first time, my experience was I told my story to someone and they immediately reduced me to a set of check boxes and gave me a diagnosis that I was not particularly interested in. And I felt like it was not a very therapeutic interaction and could have been done better. And that is, if I'm psychoanalyzing myself, I'm sure there's a lot of transference there. And I don't even know how much of it was real. But I did think to myself, gosh, I never want my patients to feel this way. I always want them to know that I'm really interested in their emotional life, and I'm really interested in the way they understand things, and I'm really interested in what they find to be meaningful in life and what their goals are for their life and what their priorities are. And I'm much less interested in 5 or 6 out of 9 SIGME caps as an example, right? That tells me some clinical information and it can certainly inform treatment planning, but I can get that on a checklist. It doesn't tell me who you are as a person. It's just a number of symptoms. And I just think I've seen it too often where psychiatry is practiced based on number of symptoms and approved pharmacologic interventions. And I just think that we need voices in the field who are advocating to do it with a little bit more nuance.
You know this already, but you're not unique in that perspective. I've heard so many times patients coming in and saying, I felt like a number. I've had friends who, come to me now that I'm a psychiatrist. A lot of people don't tell me all their stories, but many of those include, I went to a psychiatrist and all they did was prescribe me medication and that's it. And don't be like that.
And again, back to the therapeutic ritual point, people often come to us, not always, as we know, but often wanting to change, ready and willing to change at a point where they're like, things in my life need to change. I need to change my behavior. I need to change the way that I understand things because things are not working. And that's why I'm coming to see a psychiatrist. And I think that when we do not fulfill that therapeutic ritual, when we do not build an alliance, when they do not trust us, they don't feel like we really care who they are as a person, we are squandering a beautiful gift that we need to be honoring, which is someone, trusting us to help them better their life. And that moment doesn't come around very often. I mean, I think a lot of people probably see a psychiatrist once in their life. And if it's a good experience, maybe they get better. And if it's a bad experience, they say, you know what, I knew it wouldn't work. I don't even know why I did it in the first place. I knew these people were just pill pushers. And I just think it's too sacred an interaction to not be doing everything I possibly can to improve the quality of these interactions for everybody, really.
I'm glad that perspective is still out there.
I think unconsciously people know by the time they get to a psychiatrist, this pattern that I'm in is not working. And they're as close as they're ever going to be to breaking that pattern if they can get the help they need. And we need to know that when we go into the interaction, that this is a really high stakes interaction and I have to navigate it really carefully.
Right. Yeah. That reminds me of what I was thinking about, that, yeah, people are coming for a reason and most of them don't want to be there. And they probably took a long time to get there. Right? And many of our, the things that we treat have sort of, as one of the symptoms is a negative outlook or inability to trust, or, and just to overcome that and show up shows so much, unless they were brought in by police or something, but like, even then you still have to develop an alliance, right? They showed up and that required for them, that was probably something that was agonizing. I want to respect that for sure. I just realized that I haven't really asked you to talk about your professional bio, introducing yourself to everyone in terms of, where you grew up intellectually and where you are now.
I did undergrad at Spring Hill College, which is a small liberal arts school, went to St. Louis University for med school, and then to Creighton for residency. And I think that sort of Jesuit ethos really is something that I connect strongly with and is important to me. So I'm really happy to be at a school that has those values and to be able to work with the students from that lens as well. So that's a little bit more than you'd find on an internet bio for me, a little bit more than I usually disclose, but that is something that is important to me.
Do you mind giving people who don't know a little bit of a quick, probably oversimplified view of what a Jesuit ethos is?
Sure. So I was raised Catholic. I come from a Catholic family, and I've been at Catholic schools my whole life. The Jesuits are an order of Catholic priests, Catholic missionaries that has been around for a long time. They're often called the Marines of the Church, and they are sort of famous for their whole person approach to education, with spirituality at the center. And what I'll say is that Jesuit spirituality is very inclusive. It is not strictly people who practice Christianity that can find their spirituality and feel respected at Jesuit institutions. It's a place that holds space for the fact that there is meaning to this world, there's meaning to our lives, and we should be seeking purpose and connection with others, and we should be doing things that unify humanity and do not divide humanity into groups to be pitted against each other. And that is really a philosophy, indeed a theology, that I think is really important to me to have that at the center of what I am doing, so that I can always point to that at my work and say, no, this is what we're doing, right? We're bringing people together. We are solving difficult problems with love, right? This is what we're about. We're about wellness of the whole person, mind, body, spirit. We are about respecting people that are not respected in other areas of society. This is why we're here, right? And that's just kind of where I came from. So that's part of it, is that's what's comfortable for me. But another part of it is I really want to be at institutions that are very mission focused. And I think the Jesuits have had a mission that really aligns with my values.
Now that you're snowed in and I basically have you trapped behind a computer.
You do.
That you can turn off at any point in time. But you're saying things that are getting me excited and making me think of questions. Thinking of patients as a whole person, and in sometimes the word spiritual makes people because there's certain aspects of that people might have in their own lives where they think of the word spirituality and they think of some sort of very strict sort of religious type of attitude. But there's a broader definition or conceptualization of spirituality I think you were talking about that could be used in clinical practice for patients. And I was wondering if you could maybe expand a little bit on how to incorporate a more sort of spiritual view and what that might look like, even for maybe a provider who is an atheist.
Yeah, totally. I think, this is a lot of what I do clinically. It's a lot of what I believe personally, and it's not on the internet anywhere about me. It's complete. Psychiatry bootcamp is completely devoid of this sort of language. I don't really explore it, and I don't really plan to. So this will be a Psydactic exclusive, I suppose, on me. But I think that, you can look at Viktor Frankl, right? You can look at Man's Search for Meaning. And I think the antidote to human suffering is meaning, purpose, mission, feeling like you matter, feeling like your life is important, and frankly, love, And I think that when we're working clinically wearing our white coats, often we shy away from things like love and what keeps people going, right? But how many suicide risk assessments have you done where the only reason that this person is going through this life that is horrible and has not ended their life yet is they love their children? I mean, I think if I do 100 suicide risk assessments, 98 of those people tell me, I really am not having a good time in life, but boy, do I love my children. Boy, do I love my family. And I can make it work for that. And to me, that's really powerful. So I don't shy away from the word love with my patients. I don't usually tell my patients I love them. And I think when people are going through difficult things, and some of this is just basic supportive psychotherapy, but it's what does keep you going? That does sound really hard. Is there anything that you anchor to that gives you meaning, even when you're going through things that you don't feel like you could get through? And I think a lot of humans, even if they're atheists, will point to something, often it's relationships, and say, I have meaning here, and I can put up with a lot of distress, symptomatology, because I feel like what I'm doing matters and I have a meaningful existence as a human. And one of the things that I love about consult is the people that are medically admitted that need to see a psychiatrist are really sick. It's often post-suicide attempt, or maybe they just got a new diagnosis of a life-threatening problem. And when people are really sick, you start asking yourself some pretty existential questions, and those are the questions that I love to explore with my patients because I think they're things that really matter. And it is scary because I don't ever know what sort of territory the patient's going to lead me into, but I know that I can always be supportive. I can always meet them where they're at, and I can always back up a little bit and turn to something that I feel like we can agree on and that is a little bit less controversial. But spirituality is an important part of my practice. I'll just be honest with you.
Yeah, thank you for that. I'm not going to leave you just hanging there. So, I am an atheist, but I grew up in a religious tradition. It was a very kind of conservative tradition in the Midwest, and we weren't even allowed to do things like clap our hands in church. That was too much, kind of no dancing, stuff like that. And so when I was younger, that was kind of my view of what religion had to be. But the older I get, the more I realize how much meaning, I think you said the word, like what makes your life meaningful. And meaning is so important when we look at things like burnout. People can work. They say, oh, we're working too many hours. Oh, we're not taking enough breaks. And those things are important. But people who view their work as super meaningful, that doesn't bother them as much, right? They're able to do things that people who don't see their work as meaningful can't do, and overcome obstacles that other people would be like, I'd be so burnt out. And they're like, what do you mean? I love my job. That sort of thing. So finding meaning in helping a patient to think about what makes their life meaningful, I think is a super important thing for any therapist or psychiatrist to help foster in a patient.
You got it. And to be clear, I think spirituality and especially organized religion is way too often weaponized in the world. In the US, it's way too often used to exclude people, to make rules about what you can and can't do, what you should and shouldn't do. And to me, that sort of immature spirituality and weaponized religion has no place in clinical practice. There is no room for that. There is no tolerance for that. But I think we do need to feel empowered to move into meaning in spiritual realms.
We got into some stuff I did not anticipate here at the beginning of our conversation.
Same.
Those are the best ones, I think. There's a sense, and I don't think psychiatrists talk about it a lot, but it's I think it's an emotion really that people can have, but that sense of wonder, like about the world, like when you see something and it's just amazing and you want to know more, and it's its own kind of distinct thing. We have very few words for actual emotions in the English language, and so that's I think that's one of the weaknesses of the language we use in practice, in my practice anyway. My wife talks about she's a native Spanish speaker and how Americans use the word love for everything, and she's like, but we have multiple different words and they all mean different things, and you all translate them love, but that's not what it is. And I can remember growing up, and one of the things that I was taught in a religious context was the difference between different words for love, like the word eros, which is more like the romantic stuff. In fact, my son's name is Eros, so that's kind of and then there's like the more like phileo, like Philadelphia, brotherly love type love. And then there's like more of an agape, which is kind of a transcendent kind of love, where it's a love, almost kind of an unconditional, no matter what kind of love. But those are not the only three kinds of love people can have either. You mentioned talking to patients about love and the loving relationships they have in their life. And I think that it's super important. One of the things that crushes people more than anything is when a long-term relationship ends, even if it's been going really bad for a long time, and it's been so obvious to everyone else that it should have ended years ago. The letting go process is something just it's so hard for people to do. Figuring out how people can still view themselves as a whole person, love themselves, feel loved in when something that is really just tangled up in their identity is being torn apart from. They're being torn apart from that.
It's awfully aspirational, but I'm glad that we have a space to talk about it.
Right. People just being able to talk about it more than it's hard. Yeah. Wow. Do you have any questions for me, Mark? I mean, I know that wasn't really the frame that we're operating in today.
So you're generating an enormous amount of content. And I guess my question is why? I mean, you have a day job, you're not getting paid for your podcast, and yet you've been very prolific. Why do you do it?
We talked earlier about like love. We talked like I'm just fascinated. One of the reasons I chose psychiatry is because there was so much unknown about it, which is frustrating at times. I found myself during my residency thinking maybe I should just quit this because there's. I think maybe every resident thinks that at some point, because I felt like every attending I would talk to would have a different perspective on it, and they weren't directly critical of the other attendings, but they were basically saying what that other person said is wrong. You should listen to me, and for that was super frustrating for me. But I still wanted to love what I was doing, and I wanted to be able to study, and I found it very difficult. And for me, because I was even having a hard time learning in didactics, because maybe I have some issues. I've never been diagnosed with ADHD, but many people in my family have. And I can't like sit and just take stuff in. I have to be actively involved in a process. So if I assign myself work, and I know that sounds weird, but something I enjoy doing, it's like a hobby. Some people make train sets and they watch them go round and round, and I read journal articles and try to write stuff about them. And so it helps me to be engaged with content that I love in a way that's kind of fun. I used to write songs instead of read papers. So I used to sit on my porch at night when I was a undergrad and a grad student in evolutionary biology. And I just bring out a guitar. I wasn't good at playing the guitar, but I would play it, and I tried to learn some banjo and some mandolin. But I've written probably 200 or 300 songs in my life, because I'm like, well, if I want to learn how to play, maybe I should just write some songs, start about super simple, just kind of silly songs, and then worked into more serious stuff. So I just enjoyed it. It was fun. And I have the same kind of enjoyment when I download a new paper and I start to read it, and I come across a concept, and I'm like, I don't understand that at all. But, I don't know why, but for me, that's not like I need to put this down. That's okay. What does somebody else have to say about that? Because this didn't make sense to me, but I think I should understand it. Yeah, it's weird. It's just what motivates me.
So in part, it's to do sort of deeper dive think pieces to help yourself fall in love with psychiatry again when you're kind of getting beaten down in the middle of training. And then also just sheer practicality of people actually learn from podcasts. They, unlike textbooks, which collected dust on bookshelves, people might actually listen to a podcast and learn something. So it sounds like it was a kind of a combination for you.
Yeah, thanks for summarizing it so well. And I'm glad that I did it. I keep doing it. So voluntarily.
What is one thing you want every Didactic podcast listener to know about you?
I just divulged that I've written a few hundred songs. I mean, I don't know if I've ever said that before. But then there are things that I kind of want people to know about me, but I wouldn't say. I'm trying to think if anything pops to the surface right now. It's a good question. I want them all to know that I used to have dreadlocks. I was a very different person than I am today, like in my youth. I've gone through, phases is not the right word, but I've gone through periods of rapid change in my life and periods of exploration. I went to college right out of high school because my mom showed up and made me go. She's like, they're enrolling today. I'm like, okay. So I did, but then I ended up dropping out because I missed some tests because I was working late and my alarm didn't go off. And then I was like, screw this. So I dropped out of college. I ran off to live in another town with some guys who were mostly in college and kind of did the hangout. It wasn't really a fraternity, but it was kind of like one for a few months. And then from there, I ended up going down to New Mexico because my younger brother had dropped out of high school and ran away from home. And he had ended up down there and he was getting married. He invited us to his wedding. And it was really cool because I went down there and we were by this river out in this valley in New Mexico. And all these people just started coming out of the woodwork. They just started arriving. Some people with mules and donkeys, people with loincloths, like people with big backpacks, just setting things up, bringing stuff down. One guy made a big batch of some alcoholic thing where he mixed a whole bunch of stuff together, but it was in, and it was in the middle of nowhere. There's no like going to the grocery store to get stuff. And there was this huge community out there that I had never seen before. And that was fascinating. So I ended up going down there and staying down there for around a year or so before coming back. So that's a very short version of like one part of my life where things changed a lot. I didn't have a direction and I found this community that just fascinated me and went to go learn more. And I'm glad I did. I think it helps me as a psychiatrist if I had just kind of grown up and gone through from one part of school to the next, to the next, to the next, I might think that someone who did something like I did, just because they did that, was maybe mentally ill, right? I see that kind of perspective in other people where they're just like, that's so weird to me. There must be something wrong with you.
Right.
And for me, I feel like I don't start there at all. I'm like, that's kind of cool. Tell me more.
Yeah.
Because I have some experiences in my life like that. So
you have a lot of wonder and awe. I feel like you look at something and you say, that's beautiful. And you just sort of gravitate toward it and stare at it and analyze it and experience it. And then maybe something else catches your attention and you do that. You seem to be a real explorer.
I think that's probably a good word for it. Yeah, an explorer. Like I can't sit still. Yeah, that wonder and awe. I hope I don't lose it. My dad, when he got older, was kind of a curmudgeon, and my son still calls him the grumpy grandpa. And I don't want to be that, but I hope I'm not. Yeah.
You're on the right track.
Thank you, Mark. Appreciate it. Any more questions?
No, I think I'm good.
All right. Yeah, this went longer than I expected. We
It's
talked
fun,
about
though.
more.
I had a lot of fun. Yeah.
Yeah, there's a humanity. I think when that humanity, you talk about humanism. I was confused about things like the biological perspective and the psychoanalytic or psychodynamic, and then the cognitive behavioral, and all of these separate sort of factions or camps or denominations within psychiatry. And then there was the more ecumenical idea where, we can just all just get along. But in fact, we can't necessarily, because sometimes the things one people say actually contradicts others. So it's a landscape with a few minds in it. You have to be careful sometimes, and it's fascinating. But at the same time, we are more and more coming together. And in the future, the thing that I hope to see and maybe even contribute to a little bit is a way to do that. A way to do that takes what what can be demonstrated as the strengths of each approach and give them some consilience with each other.
And in areas where they are directly at odds, are we maybe talking about different patients, or maybe we're talking about different problems?
Right.
Like, yeah, supportive psychotherapy is not going to work for OCD. Doesn't mean it's bad. It just means we're talking about a different patient. So it'll be. I'm not very hopeful that things are going to be different when we end our careers than they are right now. But I feel like all you can do is put your shoulder in and try.
Well, thanks for crushing my dreams. Then.
Yeah, no, yeah. Well, it's not going to happen. You may as well just go work for a company or go deny insurance reviews or something. So that's
right.
Now that we're off the record, I can tell you that.
Thank you for hanging out with us today. I would just want to leave you with a few thoughts. Now that I've been doing this for a while, the reason that I brought this content back was because there's so much about what we do that is uncertain. But there are a few things that are truly meaningful. And I think it can be very distracting to us to go through day after day after day looking for an answer when maybe we shouldn't be looking for the answer. We should be looking for the meaning. Nothing in this podcast should be considered personal, medical, or mental health advice.